Hi, everybody. I'm Dave Wiseman. I'm an ACP guy, been a Maryland ACP a long time, and we're really excited to have this uh, journal club, we've been calling it for the last year or so. Dr. Fargahi, who is with us today, Dr. Deepak is on here too, our governor, currently of ACP, is here. Mary Ellen, Dr. Streiff. We have a great team here for everybody to introduce this particular topic. So we had an idea of doing a debate among two different programs and centering it around a patient scenario. And that is really what we're going to be doing today. So we're going to see how this works. It can be a little challenging between two teams, and we're going back and forth with Zoom. It may be a little clunky initially, but we'll see how it goes. So just to give everybody the background on the particular topic of today, has to do with the management of unprovoked venous thromboembolism. And we gave the teams a very specific clinical scenario. The scenario is this: is a 65-year-old man. He presented for the first time with an unprovoked DVT in PE, and this was not an incidental PE. He was quite symptomatic when his PE was found. He was otherwise healthy. BMI was 28. No significant medical history. No current medications at the time, other than anticoagulation currently. And he's done his 6 months. He's finished the 6 months of treatment that was deemed appropriate for him, and he follows up with you now in the office to discuss about what to do next. In the background, he had a hypercoagulable workup. We'll say that was done. His screenings are all up to date, and as everything is negative, all his cancer screenings and stuff are fine. So this is the clinical debate. The question specifically is: should anticoagulation be continued indefinitely in this 65-year-old man who has an unprovoked VTE? So I'm gonna ask Dr. Deepak to kind of give us a little thing on the Maryland ACP.
Good afternoon, everyone. Welcome to Maryland ACP Journal Club. I would also like to welcome Dr. Colleen Christmas, who's just been our past governor. This is a robust session, and I don't want to take up any more of your time. Just welcome and waiting for the results.
Unprovoked BTE.
I wonder if you guys any other.
Thank you very much, Dr. Deepak, for that introduction. And thank you very much for your continued support and on this collaborative journal club. It is my great honor to introduce Dr. Michael Streiff, Professor of Medicine at Johns Hopkins University of Medicine. Dr. Streiff is a nationally and internationally recognized expert in venous thromboembolism, anticoagulation management, and thrombosis. His major clinical and academic work has focused on prevention and treatment of VTE, including VTE in patients with cancer, vena cava filters, and evidence-based anticoagulation management. He has chaired the Venous Thromboembolism Guideline Committee for National Comprehensive Cancer Network and has served on national and international panels developing guidelines for the management of venous thromboembolism. At Johns Hopkins, he has also served in major leadership roles in anticoagulation management, helping standardize policies and procedures for safe and effective anticoagulation care. Today's debate is on anticoagulation anticoagulation duration after unprovoked VTE, and we are truly fortunate to have Dr. Streiff with us to share his expertise. Dr. Streiff, thank you very much for joining us.
Thanks a lot for the invitation. I'm looking forward to the debate. Topic I have lots of interest in. But
Wonderful. Thank you. Now we're going to introduce the teams who are participating in the debate. I'm going to introduce AMC team. Our team members is Dr. Tamam, Dr. Sergey Yudgai, Dr. Sahil Garg, and Dr. Rahul Mishra. Dr. Ward.
Hi, how are you? I'm Dr. Ward. I'm from GBMC, and I'm so proud to be here and introduce my team. I have Dr. Bakhtiar, who's a PGY1, Dr. Sadaf, who also is a PGY1, and Dr. Abid, who is a PGY3, who will be debating for us today.
Wonderful. So, Dr. Wiseman, we were ready.
Yes, and just to let everybody know how the rules of the debate will go. So we have 3 debaters in each team. We did a flip of the coin. GBMC, the yays won that debate, flip of the coin. They chose to go first, so they will lead it off. Each debater has 5 minutes, and they'll get a 4-minute warning of So at the last 1 minute, you'll get a 1 minute warning, and it has to be a sharp cutoff at 5 minutes, if you don't mind. And we do apologize about that, but sharp cutoff at 5 minutes, and then we will flip. And then please unshare your slides between debaters.
Perfect. Thank you very much, Dr. I'm just going to share my screen. This is a Maryland ACP Journal Club debate survey. So you can scan the QR code and have that on your cell phone or your computer to vote during the presentation. And we also have another QR code for voting for the teams, but just want to share it with us. I'll share it again in the middle and at the end of the session.
Yeah, and for voters, please wait to the end before voting. And if you're actually a debater, we ask that you don't vote, but everyone else can vote. So if you're participating, hold off on your vote. Everybody else can vote. Who was more effective at defending their stance in this particular case?
Great. So now I share the screen, and GBMC, all the best.
Start us off. Let me know when you're ready, and I'll start the clock.
Okay. I think we're ready to go. Let us know when it starts.
Yeah, you want to put it in show mode?
Can you see your slides?
We do.
Okay. Yep.
That's right. You can leave it like that if you like, but we can see the your small mini slides on the left.
Where is it?
You can click on the third from the left. That's small.
There you go.
Yeah.
Perfect. All righty.
Yeah, I'm ready.
Go.
Okay. Hi, I'm Dr. Bakhtiar. Thank you for introducing us, Dr. Ward. We want to thank Dr. Ward and Dr. Donegan for their kind supervision. So, in summary, we have a 65-year-old male with past medical history of hypertension and a BMI of 28 who presented with first-time DVT and bilateral PE and has completed 6 months of full-dose DOAC therapy. He is up to date with cancer screening and his hypercoagulable workup is negative. He has no non-provoking factors. Our team is going to support the proposition of continuing extended DOAC treatment beyond 6 months for this particular patient. I want to open the discussion by emphasizing that unprovoked VTE is not a disease at a single point in time. On the contrary, it acts like a chronic condition with risk of recurrence being relentlessly cumulative every year the patient is off of anticoagulation therapy. This is supported by data from a BMJ study, which shows that after being off of anticoagulation therapy for 1 year after an unprovoked VTE, the risk of recurrence, the cumulative recurrence risk went up by 10%. At 2 years, it was 16%. At 5 years, it was 25%. And at 10 years off of anticoagulation therapy, the risk went as high as 36%. This goes on to show that whether you stop at 6 months, 1 year, or 5 years, the risk of recurrence of an unprovoked VTE is going to rebound. Now let's roll back to our patient, 65-year-old male, and break down his risk factors of recurrence of VTE. Being male itself is a non-modifiable risk factor for recurrence of unprovoked VTE. Data from Khan et al. Shows that males who were taken off of anticoagulation therapy after an unprovoked VTE had 40% more chance of having recurrence compared to their female counterparts. If we talk in cumulative recurrence risk, over the period of 10 years, males who were off of anticoagulation therapy had 41.2% chance of recurrence compared to 36% over 10 years in general population. The second non-modifiable risk factor that our patient carries is his age. Data shows that risk of recurrence of VTE is 17% higher at 10 years after the initial time of incidence. This shows that, so for this 65-year-old male, if he's taken off of anticoagulation therapy at 6 months, after 6 months, when he will become 75, his baseline risk of recurrence would have already gone up. This goes on to show that VTE is not a disease that ages out with time. Rather, the risk of recurrence is always up and goes on increasing with every year. The third non-modifiable risk factor that our patient carries is having both DVT and PE together as first episode. A meta-analysis of 18 studies involving 7,500 patients showed that patients with both DVT and PE together in their first episode had 50% more chance of recurrence compared to patients who had isolated episodes of PE. And having both mixed PE and DVT as first episode also had more recurrence compared to isolated DVT episodes as well. And the fourth risk factor that this patient carries is this BMI. BMI between 25 to 30 has 12% more risk of having a recurrence compared to people with BMI less than 25. I want to pause here and raise a question for everyone. For this 65-year-old male with only hypertension as a pertinent past medical history prior to coming in with an unprovoked VTE, if this patient had MI or stroke, most of us would probably feel confident in continuing him on extended antiplatelet therapy. Similarly, if this patient had AFib, a lot of us would have felt confident in continuing him on extended anticoagulation therapy. So the question is, for this 65-year-old male with only hypertension as a pertinent past medical history, why are we hesitant to continue extended DOAC therapy beyond 6 months for him when he has three non-molecular risk factors and the data also shows that the risk of recurrence goes up if patient is off of anticoagulation therapy for long. Before I yield to my next speaker, I strongly want to convey this point to the audience that the treatment of unprovoked VTE is not curative, it's suppressive. When we are asking to treat this patient beyond 6 months for his unprovoked VTE episode, we are not trying to treat a past clot, but we are trying to manage an ongoing condition. We believe that deciding to take this 65-year-old male off of anticoagulation therapy at 6 months does not mean cure. It simply means choosing to leave the patient unprotected. Thank you.
Very well done. Very well done. Within 5 minutes. And I encourage everybody to throw the reactions in there. You can clap, please, for everybody at the end of each of the sessions. So we're going to switch over to our next debater. We're going to switch to AEMC. And by the way, Dr. Streiff, we'll have plenty of time for you at the end to vent your spleen on this particular topic.
Sounds good. We can start now.
Go for it.
Hello, everybody. My name is Tamam. I'm a second-year resident, and I'm going to open our team's argument. Okay. Okay. So we do know that guidelines such as ASH, AHA, or CHEST guidelines, they do recommend consideration of indefinite anticoagulation therapy for first unprovoked VTE. However, they also emphasize the importance of shared decision-making with the patient and that this decision of lifelong anticoagulation should be based on individualized risk and benefit discussion rather than just blindly starting all patients on lifelong anticoagulation therapy. So what really is indefinite anticoagulation? It is the number of years of treatment for a recurrent event that may not even happen. So when we look at the guidelines, we'll see that this extended anticoagulation period is highly variable. So is it 1 more year? Is it 5 additional years? Or should it be lifelong? So the question here is, how many years of anticoagulation therapy should a patient be exposed in order to prevent an event that may not even occur? So we do know that lifelong anticoagulation is effective in reducing the recurrence VTE. However, does this necessarily mean that we are improving mortality? Even though the risk decreases by the extended anticoagulation, it never becomes zero. And the net mortality benefit has not been clearly demonstrated in studies. So there is bleeding risk, which is cumulative and continues as long as patient is on anticoagulation therapy. Many VTEs are treatable, but not all bleeding episodes are reversible, such as intracranial bleedings, which may lead to permanent disability or which may even be fatal. And clinically non-major bleeding episodes, they do matter as well, as since they can cause more ED visits, they can cause more anxiety, and they also affect the quality of life. So really the question here is, are we really improving the mortality, or are we just trading one risk, which is recurrence risk, for another risk, which is bleeding risk? Indefinite anticoagulation therapy, it does change lifestyle. So these patients will need frequent clinic visits, which will can increase the healthcare burden. We know that most of these patients has comorbidities. They're taking many drugs, not only prescription, but also over-the-counter, such as NSAIDs or even herbal supplements, that they can cause drug-drug interactions with drugs and can cause
From orally go down with vicissitudes and catheter, a lot come out of this nest.
will have activity restrictions due to further injury concern and further bleeding. Let's also not forget about the cost burden, because we all know that drugs are already expensive drugs and not all insurance plans cover them. I can give an example from my own personal experience when I had a patient who was getting his drug from India because he was not able to afford it here. And lately he had to cut the pills to half because he was running out of the medication until the new box arrives from India, right? So these are some additional factors that should be taken into consideration after shared decision making with the patient, informing them about these factors rather than just uniformly starting all patients on lifelong anticoagulation for VTE. So indefinite anticoagulation, yes,
One minute.
It is effective in reducing the recurrence risk. However, it also comes with unclear mortality benefits. There is ongoing bleeding risk. This indefinite anticoagulation affects lifestyle, and there is increased cost burden. So we are proposing that indefinite anticoagulation therapy should not be started automatically for all patients for first unprovoked VTE, including this patient who is low risk. Thank you.
Very nice. Very nice. Collapse round, and then we'll switch it back to GBMV.
Good afternoon, everyone. My name is Sadaka Sadaf, and I'm a PGY1 from GBMC. We at GBMC pride ourselves on providing care that we would want for our loved ones. And in this case, it begs one question. Do I really want to anticoagulate a 65-year-old man with a history of hypertension for the next 20 or so years of his life? The short answer is yes, because the benefit outweighs the risk. For the long answer, let's start with some math. The number needed to treat and number needed to harm. You would need to treat 44 patients to prevent one PE, compared to 167 to cause one major bleed. That's a 4-to-1 ratio in favor of anticoagulation based on guidelines published by the American Society of Hematology in 2020. Now, that alone is a convincing figure. But to give the other side its due, let's break down our patient's bleeding risk with the help of two validated bleeding scores, the VTE bleed and the HAS-BLED score. On the former, our patient would score 1.5 for history of controlled hypertension and a 2.5 for uncontrolled hypertension. On the HAS-BLED, he would score 0 for controlled and 1 for uncontrolled hypertension. One variable clearly stands out here, and that is his history of hypertension. Now, I agree that hypertension is a valid concern in this patient. Based on the ANAFI registry from Japan, which stratified the annual rates of major bleeds based on achieved blood pressure, the risk of major bleeds doubles when that hypertension is uncontrolled. What that tells you is a key fact about hypertension as a risk factor, and it is that hypertension is modifiable. The answer to that is tighter control and closer monitoring, not stopping guideline-directed anticoagulation. Now, my esteemed colleagues from Anne Arundel will tell you that a 65-year-old isn't going to be 65 forever. He will age, and with aging increases his risk of one event, falls. And I agree, they're right about that. But what this really means is summarized by a study that was published in the early 2000s, which states that it would take 295 falls per year for the risk of fall-related bleed to outweigh the benefit of anticoagulation. And there's a caveat to this number. The patients studied here were on warfarin. Our patient is on a DOAC, which cuts this risk by about half. And regardless of the choice of anticoagulant, falls themselves remain a modifiable risk factor, with gait assessments and physical therapy reducing the risk by up to 50%. Now, for a final bit of math, the bottom line. What is the cost of these events? The per event cost of a recurring VTE is roughly 30 times the annual cost of the pill that it takes to prevent the event. Now, that number is staggering. For the economically astute, I will admit that this is not a cost effectiveness analysis. What this is meant to do is a clinical decision making, which brings me to my closing argument. Bleeding is loud and registers more strongly in our imagination compared to the silence of clots. A knee-jerk reaction would be to stop anticoagulation entirely, but sound clinical reasoning and value-based care is driven by data, and the data overwhelmingly supports continuing anticoagulation in this patient. Thank you.
Excellent, excellent. Back to AAMC.
So we can start, yeah. My name is Sergey. I'm one of the PGY1s from Orlando, and I'm going to talk about evidence supporting our position. So I would start with a definition. What is actually indefinite anticoagulation? And I want to highlight that extended and indefinite, it's two different entities. And if we look at measured trials such as Einstein, Amplify, and Renault trial, we see that actually all of these measured trials have definite time for anticoagulation and limited follow-up. So we need to take into consideration that and look at indefinite period with extreme caution. Also, let's see about the benefits of indefinite anticoagulation and look at this meta-analysis, for example. And we know that indefinite treatment is associated with reducing the VTE recurrence risk, but when it comes to mortality, the benefit is not proven yet. So, and we see the results of this meta-analysis, anticoagulation versus observation of placebo, and we clearly don't see any measure of mortality benefits. This is our data. When it comes to bleeding, actually, we should understand and take into account that risk of bleeding is real and substantial. And this one of the landmark meta-analysis, 14 randomized controlled trials. And the incidence of bleeding here is 1.12 events per 100 person years, which is substantial. And when it comes to case fatality rate for measured bleeding is almost 10%. As I said before, data for DOAC is limited when 1 year of follow-up. And it's important to highlight that in most measured trials, the risk of bleeding was compared between two different regimens of anticoagulation, but not anticoagulation versus observation of placebo. So indefinite anticoagulation, also the indefinite and unfortunately not fully predictable exposure to bleeding risk. Looking at our patients specifically, it's the same meta-analysis, and we see that age more than 65 is an independent predictor of higher bleeding risk. And our patient is exactly 65-year-old, and he's going to get older, so his bleeding risk is going to get higher as well. Let's look at another systematic review and meta-analysis, there's some limitations that most of these studies included warfarin, but you can see that at least 4 trials included DOACs as well, and we see that based on this analysis, the relative risk of measured bleeding events also was higher in group of extended or indefinite anticoagulation. Another study, actually, it's real world data, and it's a big Danish registry-based study. Included more than 18,000 patients, first time unprovoked non-cancer VTE, and combined group with extended anticoagulation. They actually look at patients who took anticoagulation more than a year. It was significant association with increased risk of measured bleeding. So prolonged anticoagulation, which was not well investigated in clinical trials, might be associated with high risk of severe bleeding as well. And finally, what about non-measured but clinically significant bleeding? It's also important and matters because, can I imagine the patient, family meeting, Christmas party has severe epistaxis leading to ED admission. So it's also important, and we have some data another meta-analysis looking at actually risk of non-major but clinically significant bleeding, and a group of extended anticoagulation and definite anticoagulation has higher risk of this event.
We should also talk about the financial toxicity. There are a couple of cost-effective studies out there, which I have
1 minute.
reference. Indefinite DOAC therapy after a first unprovoked VTE is not just a clinical decision, but also a cost and value decision. I know my colleagues mentioned the cost of DOAC is lower than the cost of recurrent VTEs, but the case fatality rate of 10%, what is the cost of a fatality? This cost effectiveness study that I mentioned found that indefinite DOAC therapy is about 16,000 Canadian dollars more per patient. More importantly, this extra cost was not clearly balanced by overall health outcomes. Longer anticoagulation also means more bleeding events. So, as in any other decision, the benefit has to be weighed against both harm and cost. The study also did not show a clear increase in quality adjusted life years, and I have added a tornado plot for your reference. So, in conclusion, indefinite DOAC therapy may reduce recurrence, correct, but it increases healthcare spending without a clear quality of life gain, making it
that
a
is
poor
time.
value option.
I apologize, but that is time.
That's all.
All right, we're going back to the final round now. Excellent job, guys. Back to GBMC for the final take-home message.
All right, can you guys hear me?
Well, yes, we can. Let me know when you're ready.
Excellent. I'm ready. I'm Mohsen. I'm gonna resume our talk. So from what I'm hearing from my colleagues over at AMC is that their main objection to continuing anticoagulation is bleeding. And that concern is real. But we have to ask, what version of anticoagulation are we really talking about? A lot of our fear comes from the warfarin era. Variable INRs, interactions, monitoring burden, and higher intracranial bleeding risk. That is not the decision in front of us today. For this patient, the question is not full dose warfarin forever. The question is, after 6 months of therapeutic anticoagulation for a first unprovoked DVT with bilateral PE, should we stop completely or transition to an extended phase reduced dose DOAC regimen? The 2025 systematic review and meta-analysis shown here addresses those questions. Compared with the full dose DOACs, reduced dose DOACs had similar recurrent VTE rates with relative risk around 0.94, but lower major bleeding with relative risk around 0.62. So reduced dose is not under treatment, it is dose optimization, preserving efficacy while improving the safety margins. And this fits with the 2026 ACC-PE guidelines, which recommend continuing anticoagulation beyond the initial 3 to 6 month phase for patients with a first PE without a major reversible risk factor, and recommends DOACs over other regimens. So our position is neither aggressive nor outdated. In this 65-year-old man with unprovoked DVT and bilateral PE and no high bleeding risk features in the vignette, bleeding risk should guide us toward the safest effective regimen, not towards no regimen. And this is where the extended therapy trials make the argument practical. The Amplify studied patients who had completed 6 to 12 months of anticoagulation for VTE with placebo. Recurrent VTE or VTE-related death was 8.8%, and with low-dose apixaban, it fell to 1.7%. That's an absolute risk reduction of 7.1%, or a number needed to treat of about 14 over 1 year. And major bleeding was not higher. It was 0.5% with the placebo and 0.2% with apixaban, 2.5 milligrams twice daily. Then the Einstein choice answers the fallback argument. Why not just use aspirin? Well, rivaroxaban 10 milligrams daily reduced recurrent VTE to 1.2% compared with 4.4% with aspirin. Major bleeding was essentially the same, 0.4% with rivaroxaban versus 0.3% with aspirin. So aspirin gives up substantial protection for almost no meaningful bleeding advantage. That is why reduced dose DOAC is the evidence-based compromise. It is not full dose anticoagulation forever. It is not stopping therapy and hoping nothing happens. It is extended phase secondary prevention using the lowest effective intensity supported by the randomized trial evidence. When the other side says we are worried about bleeding, I agree. We are worried about bleeding too. That is exactly why we choose the reduced dose DOACs. But we're also worried about recurrent PE, and they are asking for mortality proof from trials that were designed to measure recurrence while ignoring the outcome those trials clearly proved. Recurrent VTE and recurrent PE are substantially reduced. If the opposing side wants to stop anticoagulation because mortality benefit is not definitely proven, then they are accepting the clearly proven increase in recurrent VTE to avoid a bleeding risk that is very low with reduced dose DOACs. Stopping anticoagulation removes the bleeding risk, but it also removes protection. For this patient, stopping is not the safer option. It is the less protected option. I want to close by being clear about what our recommendation means. We are not saying this patient signs a contract for anticoagulation forever, no matter what happens. We are recommending extended phase anticoagulation because today his recurrence risk outweighs his really bleeding risk. But this decision should be made with the patient, not simply for the patient. Shared decision making means explaining both sides honestly: recurrent PE risk if he stops, bleeding risk if he continues, and the fact that reduced dose DOACs is designed to preserve protection while lowering the bleeding risk. And then we reassess at least annually and sooner if his situation changes. If he develops renal dysfunction, recurrent major bleeding, uncontrolled hypertension, frequent falls, or interactive medications, or a major change in goals of care, the balance may change. And that does not weaken our argument. It makes it more patient-centered. For this patient today, the evidence supports continuing into the extended therapy, and the long-term plan is not set it and forget it. It is continue reduce dose DOAC, monitor, and reassess over time. Thank you.
Very impressive. Wow, just under time. Well done. All right. That is GBMC's final argument has been reached, and we're going to go for the final rebuttal. AAMC, you're up for the final rebuttal.
Yep, you can start now.
Thank you.
I'm Rahul. I'm PGY3. I'm going to do the final rebuttal of our team stand. So I hear from the opposing team that these guidelines do recommend indefinite anticoagulation. But however, the question today is for this specific patient who is a low risk, what's the best way going forward for him? Is in extending his anticoagulation is really the best choice going forward for him? And for answering this question, we have to kind of trade off the risk of bleeding versus risk of recurrent VTE and what's the complications out of those. So we hear from the opposing team that the VTE recurrence risk is real. But as the study shown, it's mostly front-loaded. But if they continue on anticoagulation, the risk of bleeding is cumulative and lifelong. And I'll explain the data in the next couple of slides here. So as this slide was also shared by the opposing team earlier, the cumulative recurrence of VTE, if we decide to stop the anticoagulation after initial treatment, it's real. It is 16% at 2 years and cumulatively increases at 36% at 10 years. However, the case fatality or the VTE that would kill the patient, the risk is 4% from that. However, if we continue the anticoagulation, the risk from dying with major bleeding is 10%, which is close to 2 to 3 times compared to VTE recurrent risk. And this risk cannot be ignored for this particular patient. So we are here trying to trade off one risk of bleeding versus recurrent VTE. And this study by the Khan et al., they tried to answer this question using a big statistical modeling. They accounted a lot of studies which looked independently of these individual risks and made a model. In this statistical model, per 1,000 patients were age 55 or above and had initial 3 to 6 months of therapy. If we continued the anticoagulation, it reduced 368 recurrent VTEs and prevented 14 fatal PE. However, it contributed to 114 major bleeds, 30 of them was intracranial hemorrhage, and 11 bleeding deaths. So indefinite anticoagulation is not a neutral choice, and this is kind of trading a risk of bleeding versus recurrent VTE. And as we have already talked about it, that the indefinite anticoagulation causes lifestyle restrictions, and induces anxiety around the falls and surgical procedures, has drug interactions, and also needs to monitor renal function around it. And talking about the known major but clinically significant bleeding, these are just the tip of the icebergs. As my colleague already mentioned also, these can lead to ED admissions, stress and anxiety, and they can ruin patients' social events, and a lot of related complications from these known major bleedings need to be considered as well. So we are not asking to blanket follow for all patients, and we have certain decision-making tools. For example, in these situations where we are undecided, what's the risk of bleeding versus risk of anticoagulation? So these are certain tools that we can use to quantify those risks. And so what we say here, we hear the concluding remarks from our opposing team. We suggest structured reassessment of this patient. We don't want a blanket approach from a recommendation for this specific patient. We balance the risk of bleeding, we discuss with patient goals, and we closely follow up about the recurrence. So we suggest that we stop anticoagulation after 6 months of treatment, after shared decision making, and we are not abandoning the patient. We'll be actively following up. And I will conclude my presentation asking a simple question. How many of your patients would actually choose indefinite anticoagulation if we put out the risk of fatal bleeding versus fatal BTE risk of anticoagulation? Thank you.
Wow. Fantastic. I think big round of applause for all our debaters out there. Amazing. 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 Dr. Fargahi, you would, before we get into Dr. Streiff's comments, maybe we should put the voting code up. And I would encourage maybe if any resident on the call here today has questions for either team that you want to direct a question to.
Yes, absolutely. We have time, Dr. Wiseman.
And then we can put the vote, we can start the voting up first as well. So please, we ask you to vote for which team you think defended their stance better. We have our GBMC team. It was prolonged anticoagulation after unprovoked DVT-PE, and AAMC that was not against that prolonged anticoagulation.
Dr. Wiseman, can you see the QR code?
I think we can. See if it works.
First of all, thank you, Dr. Wiseman, and thank you both teams. That was an excellent and thoughtful debate. Well done. So we have two codes. This is a QR code for the Journal Club debate survey. We use it as to understand how we did and how we can improve for our next sessions. If you want to scan it and answer the question now, or you can keep it until the end of the session and answer it by then. I'm gonna unshare and share another QR code which you can vote for the team that you thought had a better performance.
You.
So we please answer your to the clinical position, and I'm gonna take this slide off before Dr. Streiff start his commentatory section.
Yes.
If you have, Dr. Wiseman, if we have any questions from the audience, we can.
Yes. If there's any question for the audience to direct at any of the team members, please ask them now. Get your votes in.
I think there are some question, one
Is
question.
there questions in the chat? Sorry, I wasn't monitoring.
Yeah.
Question from the chat says, for the NNT for PE presented by the pro anticoagulation team, were those clinically relevant pulmonary embolisms? Good question. So maybe someone from the GBMC team can answer that question. So again, it was regards to the number needed to treat for the PE that was presented. Were those clinically significant pulmonary embolism?
I can take that question.
Thank you.
The data is for any BE. It doesn't stratify based on clinical relevance. And I guess the rebuttal to that would be major bleeding, but any major bleeding, and major bleedings are also of different types. And the one that we're most worried about on the other side argued was intracranial hemorrhage.
Thank you.
I'm gonna
Good.
just unshare the screen, Dr. Whiteman.
Yes. If
Did-
there's no more questions, I think we can go to Dr. Streiff for some remarks about
Yeah.
the debate in this topic.
Dr. Wiseman, I'm just gonna share the
I want to say, I guess, add my comments to the ones that have already been made. That what an outstanding job from both groups. I really
thank
was
you.
awesome. It was really awesome, and I think it's. I run an anticoagulation clinic, so I guess I'm kind of biased, but but I think so. I think it's AAMC had a harder task, I think, in this, and I think that's because our drugs have gotten so much better. That when I was doing my clinical training, this may seem like eons ago. Some will be there with me, but we had like Lovenox and heparin and warfarin were like our choices. So there wasn't much out there. And so those were the bad old days. I think nowadays our options are so much better, especially with the like low-dose DOACs. And so I generally, a lot of patients, to make the bleeding low, so I would say both teams emphasize the importance of doing a patient shared conversation with the patient. What are their values? What are they most fearful of? And I do that every clinic when I talk to people when we get to this 6-month time frame. But it's very important, as both teams talked about, to do this every time you see the patients and see how they do. A lot of the bleeds, I would say that the AAMC, emphasize, the clotting is front loaded. Bleeding is too, although I agree the bleeding risk will be there as long as you're on anticoagulation, but it does come down from the initial 3 months is when you see a lot of the bleeds, because you're kind of testing the patient. The patient's getting exposed to anticoagulation for the first time, and so you kind of discover who's going to not tolerate that. So a lot of it's front loaded. And then once you get through 3 to 6 months, the bleed rates do come down, but then they kind of stabilize and go out forever. And so I think our job is, one, at the 6-month mark, kind of discussing the data, as you both did. Both teams did an excellent job looking at the literature and using literature to support their position. I think it's harder with DOACs, with the low-dose DOACs, which I use a good bit, to support not treating someone with an unprovoked pulmonary embolism or DVT and pulmonary embolism. I would say that's in my, I guess my system of categorization, I would say that's not a low risk patient. That if you have someone that's got an unprovoked event, as we saw from the con data, those are people that they're intrinsically hypercoagulable. And it doesn't matter if you've found some thrombophilic state or not, they're people, they're going to have another event if you don't have them on some form of anticoagulation. It's just a matter of when. And so I generally share with them the con data, which is an excellent meta-analysis, or that I think there was the Ali meta-analysis too, looks at the same data, shows the same thing, that you're going to have 10% at 1 year, 16% at 2 years, 26% at 5 years. And those rates are much higher. And if you have a pulmonary embolism, you tend to, what your initial event is, tends to be your recurrent events. About there's data from Jim DeCatis from years and years ago, looking at, this is back in the warfarin era, but looking at the randomized controlled trials cohort studies back then, that about 75 to 80% of the time, if you have an isolated DVT, that's how you're going to present for your recurrent event. So not always the case, but most of the case. And same thing with pulmonary embolism, you're going to present with pulmonary embolism. And so I take that into account too. But so if you have someone who's an unprovoked pulmonary embolism, they're at high risk for having another event. And so those are the kind of people I keep on long term. Also, he's a male, as GBMC pointed out. Men have a higher rate of recurrence than women. So that's something else that would bias me toward continuing anticoagulation in that patient. But then about 6 months or so, 6 months to 12 months, we had discussions about moving to a lower dose. I would say things that bias me against doing that would be BMIs. That if you look at the Renov study, that the bleeding, in the Renov study, they looked at clinically relevant bleeding. And I think in the full dose group, it was like 15%, 16% at 5 years. That was at 5 years, although median follow-up was like 38 months or something like that. And it was about 9-something% in the low dose group, for clinical relevant bleeding. So that's bleeding that brings you, it's not just major bleeding, that's major bleeding and any bleed that brings you to medical attention. So in people that were obese, you didn't see that benefit of the low dose group, but there was a trend toward higher recurrence rates, not statistically significant, but a trend toward higher recurrence rates. And so I would, if you have someone that's over a BMI of 30, then that's something I get worried about. And then maybe just drug levels, simply that as your body weight goes up, your blood volume goes up, and drug levels, may not be adequate. That's a guess. They don't, we don't have data that suggests that, but that's how I kind of frame it in my mind. And so if I have someone that's morbidly obese, I'm not talking about low dose therapy unless they, if they're having a lot of bleeding issues, then we talk about it. But I'm not there. That would bias me against going to low dose therapy. Something else is that getting rid of aspirin is something we have to think about every, why is someone on aspirin? Do they need aspirin? And there are lots of studies now showing that we overprescribe aspirin, that we don't have to, if you've got somebody on anticoagulation, you don't need to have them on aspirin. Even with stents further out, when you get further out, you don't need aspirin. Obviously, if they have stents, I talk to the cardiologist, but a lot of times aspirin's overprescribed. And so I talked about that with patients every time. Also looking at non-steroidal use. Are they using non-steroidals? Try to keep that to a minimum because of the bleeding risks associated with that. And then look at their other medicines every time they come in to make sure there aren't medicines that are, they have drug interactions. Now, DOACs have a lot fewer drug interactions than warfarin. Warfarin is like a nightmare for that. But DOACs a lot fewer, but there are some drug interactions. And then I guess the last thing I think about would be if they've had any surgeries. This is actually kind of, I go through this early on. If they come to me in the clinic to discuss like treating their anticoagulation, it's important to note, have they had gastric bypass surgery? Have they had a Roux-en-Y or a biliary diversion procedure? Those procedures eliminate large sections of the GI tract where the DOACs are absorbed, so you put them into at risk for higher recurrence rates. And I'd say the only DOAC you could really use with a Roux-en-Y or a biliary diversion procedure would be apixaban. And in that case, I usually measure levels. I know that I'm not a big level measuring person, but I want to make sure that they're getting drug levels in the treatment range. We don't know what, first admit, we don't know what the drug levels mean, but I want to see if they're absorbing enough drug to get into the treatment range, because I've had people come to me from, they have pancreatic cancer. They're on a DOAC. They come to me on rivaroxaban and their drug levels are 0. And it's just, people don't think about it. Surgeons aren't going to think about those things. But if you get somebody come in your clinic, they just had a Whipple, make sure that they're not on dabigatran or rivaroxaban, because in my experience, you're not going to absorb levels of those drugs, and you need to be on either a low molecular heparin or apixaban. And if I use apixaban, I always measure levels to make sure that we're getting enough absorption, because they've removed the duodenum, which is where a lot of that drug is, those other drugs are absorbed. And as far as cancer, so there's lots of data now for low dose regimens in non-cancer patients. There are also lots of data in cancer patients. Well, there's a large study, the EPICAT study that was published last year in New England Journal. And that showed that, in that study, I think they were treated at like a median of 8 months or so. They were then randomized to low dose versus full dose therapy. And there really wasn't a difference in recurrence rates between the two groups. I would caution, though, if you look at the study group, that I would say overrepresented were breast cancer, colon cancer, lung cancer, and underrepresented were the really bad actors. Like, I don't think they had any gliomas, like brain tumors, which makes sense. They had fewer pancreatic cancers, gastric cancers, so they're really bad actors. And so, and also if you look at the performance, their ECOG performance status, they were like really healthy patients, like 0, they were all 0 or 1 performance status, except for a few percent. So they had a healthy population that had cancer. If that, I don't know, it's kind of conundrum, but a healthier cancer population. So I just worry if you have somebody that's got like cancer that's recently progressed, they're not doing as well, they have pancreatic cancer. I'm not considering the low dose regimens in those folks. I don't know what others. I know Bob Donegan probably makes these decisions all the time. We talk a lot, so though that's how that's my takeaway on the EPICAT study. I think it's good for people who are in stable, like breast cancer, stable disease, not having recurrence, etc. Than I do low dose. And I guess the other major anticoagulation, there have been a couple. I guess there was the COBRA study that came out recently. This isn't so much duration of therapy, but that was published recently, New England Journal, looking at rivaroxaban versus apixaban, a randomized trial that showed that there was rivaroxaban associated with more bleeding. It's again front-loaded, and probably front-loaded worse. I mean, I think Riva probably does worse because they have a 3-week stepped-up regimen. I think that's probably it, but that's the regimen we have to deal with. So I don't, I think it's built into those two drugs unless you develop another regimen, standardize another regimen for rivaroxaban. I think that's just part of the drug. But I think also rivaroxaban is associated with, if you look at population studies, rivaroxaban is associated with more bleeding than apixaban. These are observational studies, but there's been some of the Annals, the Lancet, a lot of different over the last few years, phase 4 studies that show apixaban is probably the best drug for clot recurrence and the best drug for bleeding. So that tends to be my go-to drug. I think you guys did a tremendous job. I agree. This would be like a TED Talk or something like that. I feel like I'm like, it's hard to follow that.
This is amazing. This is amazing. I can't thank you enough.
Oh my God, I'm about to try to follow that because it was so evidence-based. You got all the right studies. You really did. I mean, you covered the best studies that are out there right now. But I don't know. I want to open it up for questions. I mean, so right now what I do is I do exactly what they suggest, both sides, and I see what the patient values the most. But in general, like because of the safety of the DOACs, especially low-dose regimens, I'm steering a lot of patients toward those and then trying to eliminate aspirin, try to, obviously manage blood pressure, other things that can increase bleeding risk and limit nonsteroidals. The bleeding scores like the has bled, the VTE bleed, the RE8, they're okay. I don't use them very much because if you look at the discriminative power of those, they're in the 0.5, they're like a flip of a coin. They're like 0.55 to 0.62 or something in the studies that have used them kind of prospectively. So they're not ready for prime time, I get, for using like routine use and saying, oh, this person's has bled is high, or this person's VTE bleed is high. I got to stop anticoagulation. I never use them in that context. I always talk with the patient. I don't rely a lot on those scores because I just don't think they're good enough yet. I don't know what other folks do.
You just flushed us with a sea of pearls. That's unbelievable.
Oh no!
It was amazing. And I agree. Hasbro studied a very specific patient population that we tend to apply to a broader population that was really not meant for what it was meant for. I 100% agree. And such key points as you meant regarding, when to use low dose, when would you consider the higher dose in the higher BMIs, in those other patient populations you mentioned, thinking about the absorption of the drug. Those are just such critical components when we make these decisions with our patients. And there's more great comments in the chat. I think Dr. Krull has mentioned about the insurance coverage, and that always plays a big role in these decisions.
It does. Yeah, some of you're stuck. I mean, I don't like the Bigotrain, but Priority Partners, I'm using it if I have to. It's better than warfarin. It's more convenient than warfarin, but there are things you have to watch out for that too. But
absolutely. Well, yeah. A question just popped in the chat, and this may be a little orthopedic. The orthopedic folks tend to use aspirin as a DVT. Well, there is evidence in that patient population specifically with the post-op patient.
Yeah, I would say that and our group here is using that. We try to steer them to using that in the standard risk patient, that if people have had previous clots or clots after surgery or cancer, which that doesn't come as much, but cancer, or thrombophilia, that we're trying to steer them away from aspirin toward an anticoagulant prophylaxis. And a lot of times they're using apixaban in that rather than a low liquid heparin, but they are using a lot of aspirin. And there are studies showing that, there isn't, a great increase in clinically relevant thrombotic events. I would say that there is the Crystal trial. This was it in Australia that showed more distal DVTs in the aspirin group. But there again, most of the trials are focusing on like standard risk patients. I'd say high risk patients, I wouldn't use aspirin. I'd be worried about it. So that's what we advise. I don't know if they're always doing that, but that's our guidance document. We come up with lots of guidance documents that who knows if they're using them or not. Well,
Thank you very much.
all left out there. Like I said, I do this little part of medicine, clotting and bleeding, and a little benign hematology. So I've got the, I guess, luxury of just focusing on one area. So
Streiff, we appreciate everything you do, and it's amazing that we have you here today. We're indeed lucky that you were here with us today. Thank you.
A pleasure. These talks are awesome. These guys did
a bang up job.
thumbs up.
Round of applause, everybody.
Yep. 10 out of 10.
Thank you so much.
It's a great job.
Thank you, Dr. So just before we finish, I would ask all the attendees if you could please scan the survey and just complete the survey. We had 94 attendees vote for the winner, 94 votes, and the winner is GBMC. 60% of the attendees vote for GBMC and to continue coagulation. Dr. Stark, I just have a question. If a patient decides to discontinue an anticoagulation, what kind of follow-up would you consider? Is it a D-dimer, delta D-dimer, ultrasound?
I mean, I guess what I do is that if someone's going to, if we're going to stop anticoagulation, I often get a baseline ultrasound at the end to see where we are in case they come back with like squirrely symptoms. And this is not evidence-based at all. This is all just, I do that to know where I'm starting. If they have a DVT, obviously. For as far as like the risk stratification tools, that's, like the Vienna score, there's a VT predict score, and Geneva has a score. There's several different scores out there. Unfortunately, those are also they're not perfect. So I kind of look at them, but I put tons of confidence in them that they're still not perfect. I think the best one is probably the VT predict score. But then they have lots of legal document you have to sign and say, or click on and say, I agree. It's not a medically approved tool. But at any rate, D-dimers, there was a study by not Agnelli, one of the Italian groups. I can't remember the first author's name. A couple of years ago, where they randomized, I think it was Apodulsis was the name of the study, and D-dimers weren't perfectly sensitive. So they were people that had low D-dimers. They measured them on therapy and at a month out, and they may have measured them several times during a month out after stopping anticoagulation, and they still were people having events even when they had negative D-dimers for all the time points where they measured. They may have gone out to 3 months. It's been a while since I looked at that study, but they're not perfect either. So I think there's unfortunately no perfect tool for risk stratification for VTE, for trying to decide whether someone's at risk for recurrence. And I personally had that where people that had D-dimers, they look good. I said, okay, well, so I tell them what symptoms to look for. I may get an endotherapy ultrasound. I don't do follow-up CT scans unless I'm worried about an event. I guess pulmonary hypertension, they didn't talk about that, but obviously they have ongoing pulmonary symptoms. They get echoes and refer them to a pulmonary hypertension clinic, or VQ scans. Yeah. So I tell them what symptoms to look for. If they're coming off anticoagulants, they look for the DVT symptoms, the PE symptoms. Please contact me if you have any symptoms.
Thank you so much, Dr. Streiff. Thank you, Dr. Wiseman. Thank you to
aspirin. You could do aspirin. 30% relative risk reduction. You could if they refuse to take anything else. I've had people, cops, and pilots and stuff where they just say, I can't take it. So, yeah.
Wonderful. Thank you.
Sorry, I went over.
Thank you, everybody.